So this is the second podcast of the shock PowerPoint. So nursing management for the end organ involvement stage is the same treatment as we do for shock. We just are recognizing now that the patients are failing to respond to treatment, and we discuss that with the family. The focus of our nursing care is continuing to monitor the patient, but we're trying to prevent any further complications, infection, skin breakdown, those kinds of things, protect from injury, i.e. skin breakdown, um, or injury from treatments such as pneumothorax, and providing comfort. We might want to get palliative care involved to help with that. And a big part of this phase is communication with family about the outcome, explanations about what is happening, offer opportunities to see, touch, and talk to the patient, spiritual advisors visits, and just be honest with them. Get them in touch with the physician so the physician can talk to them also, and help them come to terms with what's going on. So let's break down some of our management strategies that we've talked about in the different phases and talk about them a little bit more in depth. So our fluid management strategy is to try to restore intravascular volume. The patient should have a central line placed. Number one, because when we get to the next strategy, vasoactive medications, they'll need the central line for those, but we can give rapid administration of fluids with a central line. Also with the central line, we can measure the central venous pressure, or the amount of fluid coming into the right atrium, which is also known as preload. Typically, we're going to start with crystalloids, and we like isotonic crystalloids like normal saline or lactated Ringer's. However, if we're trying to pull fluid out of tissues and into the vasculature, we might use a hypertonic solution like 3% saline to try to draw that fluid out of the tissues. We need to expand volume, either until we can give blood products or in place of blood products. We might give things like albumin, dextran, and hetastarch. They're all known as colloids. And then we have our blood components, packed red blood cells, platelets, and FFP. Sometimes patients don't need the whole component of packed red blood cells. They just need help with clotting, so they can get FFP and platelets. Vasoactives. The goal is to improve hemodynamic stability when fluids alone cannot. Maintain that adequate mean arterial pressure. Vasoactive medications mean that they act on your vascular system. They are not given for heart rate. Now, some of them have side effects that will affect your heart rate, but vasoactives are never given for heart rate therapy, either to increase it or decrease it. You'll want to remember that for a future test question. What do? They increase the strength of myocardial contractility. They reduce myocardial resistance, also known as afterload. They initiate vasoconstriction, and like I said previously, they should all be infused through a central line. So let's look at this list of medications and go through these. So usually if we're in class, I'll have you tell me about these medications. These medications are on your ICU med sheet, and you should be looking at that ICU med sheet, going over these medications. It will help you not only when you go to your ICU clinical, but also for this content. Dobutamine is one of those vasoactive drugs that helps with increasing contractility. Side effect of dobutamine, it increases your heart rate. Dopamine, also side effect of increased heart rate, but at different dosages does different things. At 2 to 3 micrograms, it'll actually, it's thought to increase renal perfusion. So it might be given to increase renal perfusion at a very low dose. At 5 mics and above, it vasoconstricts and increases your blood pressure. Nitroglycerin dilates smooth muscle, so it vasodilates and helps lower blood pressure. Nitroprusside is a very potent vasodilator. In fact, we hardly use this anymore at all. It can take your blood pressure from 180 to 70 in seconds. You can put a syringe in the line and draw back and suck it out of the patient and have their blood pressure come up. That's how quick acting it is. So you almost have to be constantly with your patient when they're on this medication. Norepinephrine, also known as Levophed. This vasoconstricts to increase your blood pressure. A little side note, when I was first a nurse, norepinephrine was like a last line drug. The saying was Levophed or leave them dead. Now it is our first line vasoactive drug for vasoconstriction and increasing blood pressure. So it's funny how things change in the course of time. Epinephrine, it's our catecholamine, and it not only increases your blood pressure through vasoconstriction, it also increases myocardial contractility. Side effect that is, though, that it can make you tachycardic. Milrinone, also known as Primacor, this is an afterload reducer. It's going to decrease your systemic vascular resistance and make it easier for the left ventricle to pump. So it can actually lower your blood pressure with that afterload reduction. You have to be careful with this drug. Vasopressin is like epinephrine, where it's naturally released in the body. We use vasopressin usually in septic shock. Very potent vasopressor. Really need to monitor the integrity of your extremities, your fingers and toes, and make sure they don't start turning purple, because it will really vasoconstrict. We give it at very, very low doses, but it is very effective in septic shock. And then phenylephrine, or the trade name is neosynephrine, vasoconstrictor to help increase blood pressure. Our management strategy for the respiratory system is we want to increase the amount of oxygen carried by the hemoglobin. So we're going to monitor their pulse ox continuously and do frequent respiratory assessments. And like I said previously, we may just give oxygen, or they may require mechanical ventilation. Another management strategy is nutrition. We need to maintain caloric needs. Shock increases our metabolic rates, and that increases our caloric need. And by being so sick and just laying in bed, our caloric needs can be 5 times of what they are being healthy and being active. So this is when we get dietary involved, and they look at what's going on with the patient. They figure out their caloric needs and what's going on with organs, and prescribe the best tube enteral feeding or tube feeding that would be best for the patient. So if we don't meet the caloric needs and they aren't met, skeletal muscle will start to break down to try to meet those caloric needs. And when you break down your skeletal muscle, you prolong recovery time. We need to start this therapy as soon as possible, so that the patient doesn't get behind with their caloric needs. And we need to make sure we have stress ulcer prevention in these patients, because they are going to be secreting a lot of acid in the stomach from the increased stress level the body's under. So let's look at the types of shock. Hypovolemic, we are at a loss for volume, whether it's just fluid or it's actually blood that we're at loss for. Cardiogenic, we have something wrong with our pump or our heart. Distributive, meaning we have something wrong with our vascular system, and we're going to see that with septic, neurogenic, and anaphylactic shock. And then we have obstructive shock, where something is obstructing blood flow, whether it be cardiac tamponade, tension pneumothorax, or pulmonary embolism. So in the next podcast, we're going to talk about these different types of shock. Some will be a review for you that you've had in previous courses. And then there's a whole separate PowerPoint on pulmonary embolism that we will review. A little bit about multiple organ dysfunction syndrome. It's not the same thing as shock, but shock is one of the causes. It's altered organ function in acutely ill patients that requires medical intervention to support continued organ function. It's defined of at least 2 organ systems lasting at least 24 to 48 hours in the setting of sepsis, trauma, burns, or severe inflammatory conditions. You can see the mortality rates. It accounts for 80% of ICU deaths. You have a 40% mortality rate with 2 organs, and that jumps to 80 with 3 organs for 3 days. Some markers of this syndrome: hypotension, tachycardia, dysrhythmias, decreased systemic vascular resistance, meaning vasodilation, need for vasopressor support, abnormal CVP. It can be either low or high. Pulmonary wise, you're going to see dyspnea and tachypnea and hypoxemia. Renal, we're going to start to see an elevated creatinine, oliguria, and life-threatening electrolyte imbalances. Neurologic, we're going to see anything from confusion and delirium to lethargy, coma, or seizure. Endocrine, we're going to go hyper or hypoglycemia. We may see some adrenal insufficiency. Our hepatic system, we have elevated liver enzymes, hypoglycemia, decreased albumin from the decreased protein, jaundice. We may have some clotting disorders, thrombocytopenia, coagulopathy, increased D-dimers. We're going to have a metabolic acidosis and elevated lactate. So a lot of the things that you see in shock once it involves organs. Prevention is our top priority. We need to be able to pick out which patients are most susceptible to it. Most common organ dysfunction is renal failure and ARDS. Subtle signs can be a change in mentation or a gradual rise in temperature. We need to control the initiating event, promote adequate organ perfusion, provide nutritional support. Our patients that are most at risk are elderly, immunosuppressed, malnourished, those with chronic illness, and those with surgical or traumatic wounds. So that was a little bit about multiple organ dysfunction. Please bring your questions to our Zoom session. And that is it for our overview of shock. The next podcast series will go into types of shock.